Hi, I'm Richard Semelka, and I am going to go over today with you how I read body MR cases. So we're going to look at entire cases, and I'll show you how I look at the images, how I look at each individual sequence. I'll also describe strengths or weaknesses, and if there's problems with any of the sequences, we'll go over that. Basically, what I'm going to do is I'm going to verbalize exactly what I'm thinking when I look at cases, and this will give you an idea of my approach to interpreting body MR. Now, many of you will have read my textbooks, you probably will have seen some of my publications and also presentations, but in all of those settings, you'll only see 4 images from any particular case. Body MR, as you know, oftentimes has anywhere from 600 to 1400 images, and I'm going to show you how I go from those 600 to 1400 images to make a diagnosis, and in selected cases, the way I would set up a teaching file. So let's roll up our sleeves and begin. So I'm going to show you on this one screen. Now, I usually look with 4 images on a screen, but for the sake of this production, I'm going to show you just 1 image on the screen. So it's a little bit different than I would look at it myself, but this should then make things more clear for you. So the first images that we acquire are the single shot T2-weighted images. And I page through the images I get because I'm looking at the biliary tree in everyone, which is right here. I'm looking at the bowel, which is nicely shown in these coronal images. I look at the heart and I look at the lung bases. And of course, in this particular case, we identify multiple large masses throughout the liver. Now, I would describe these masses on this set of images as heterogeneously high in signal intensity on T2. Now, the next set of images that I'll show you is the transverse fat-suppressed T2-weighted image. Now, what you notice is that we have multiple lesions now in the liver, and again, it's important to semi-quantify, if you like, how high the signal intensity is. So I describe these as moderate in signal intensity. So these are not low signal intensity, as we'd anticipate, or minimally high in signal intensity, as we'd anticipate for typical lesions of hepatocellular carcinoma, typical lesions of FNH or adenoma. These are moderately high in signal intensity on T2. This is now an out-of-phase T1 weighted image. I recognize it as T1. I look at the spinal cord and I see the CSF around it is dark. I also see dark rings around structures like the kidney, so I know that this is out-of-phase T1. In this case, we can see that there are regions of high signal intensity throughout certainly the larger of these masses, and high signal intensity on out-of-phase, and we want to compare it to the in-phase, which I'm showing you now. This is the in-phase. Both the out-of-phase and in-phase T1 showed it to us as high signal intensity, so we know it's not fat. That leaves us with either blood or protein as the most likely explanation for this high signal intensity. So these are the in-phase T1 weighted images that we page through. Again, we identify the multiple masses, many of them well-defined and low signal intensity on T1. Moving on, this is now non-contrast T1 weighted fat-suppressed images. We recognize it as fat-suppressed because the fat around the kidneys is dark. And fat suppression is a very good way to emphasize high signal intensity that we may see from either blood products or from protein products. And you can see that this is very high signal intensity on T1. So we're thinking large masses, some of which with high signal intensity material on T1 weighted images. Now, routinely we get a thick slab MRCP image, which takes only a few seconds to acquire. And that's useful to give us an overview, and at times we may not see the duct system that well. In this case would be such an example, but here's the left and right bile ducts, the common hepatic duct, and we kind of lose the common bile duct here. This is probably a portion of the pancreatic duct as well that we're seeing relatively well, but that's not the focus of this case. But we routinely get this to give us an overview of the biliary tree. Now this is a new sequence that we're working with. This is called radial vibe, and for the purpose of this presentation I won't go into details with this, but this is a sequence which is very effective at controlling phase artifacts. And we can see very nicely this large lesion and the other lesions throughout the liver. Here we see another fat-suppressed T1 weighted image, also radial vibe. Now, oftentimes the most important of our data sets is the hepatic arterial dominant phase T1 weighted image. And what I look for in everyone, that the pancreas is high signal intensity and enhancing greater than the liver on a correctly timed phase. We can see contrast in the aorta, we can see contrast entering into, this is the superior mesenteric artery. At this point in time, it's a little bit earlier than I'd like, because I don't see contrast in the superior mesenteric vein, but I do see contrast in the splenic vein, and therefore I do get some contrast in the portal vein, but much of this contrast here is in the hepatic artery. But we can see that these masses are enhancing in a diffuse heterogeneous fashion, which is typical of primary malignant lesions of hepatic origin, including this larger lesion. So we have the hepatic arterial dominant phase. Now the next phase of enhancement, and again, this is a little bit earlier than I'd like, and I would probably call this true late hepatic arterial. The next phase we call early hepatic venous, oftentimes referred to as portal venous phase, but in these images we generally see contrast in the hepatic vein, so that's why I think it's more appropriate to call it early hepatic venous. What you also notice when you look at the IVC looks funny, and we see small little black dots around it. Well, this is a transplant liver. And so we have in a transplant liver all of these multiple lesions, and you can see that what's also interesting is that we are getting some late capsule enhancement, but many of these lesions are actually retaining some of the contrast, so they're not washing out as we'd anticipate with a traditional or conventional HCC. They're retaining contrast. The other thing that was unusual for hepatocellular carcinoma is that the lesions were moderately bright, as you'll recall, in the T2 weighted images initially. Oftentimes HCC, the smaller ones, tend to be somewhat isointense on T2, but they were relatively bright. And that's going to lead to what I suggested the diagnosis was, and then we found out subsequently that in fact I was correct. And it's something that we're currently working on, so it's a very unusual case. And here we can see that the masses of tumor show peripheral enhancement. Centrally where we saw the blood, it's not enhancing, so we call that central necrosis. We always get coronal images. Gives me a very nice look at the portal venous phase, and I always want to see that as a direct acquisition. I don't like to reconstruct from the transverse images the coronal plane, because oftentimes we may get trouble on early passes post-contrast seeing heterogeneous signal in the portal vein, and if we simply reconstruct it in the coronal projection, we'll see that same areas of heterogeneous signal. By directly acquiring the coronal plane, then I can be more sure that I'm seeing patent portal veins. In this case, we are seeing patent portal vein. This is the main portal vein. This is the superior mesenteric vein here. And we can see that these are patent. We can see these multiple heterogeneous masses throughout the liver. And this is not a typical part of our sequence, but this is the radial vibe sequence. Again, a sequence that's very resistant to motion. We're doing some research currently with this sequence. So now let's go over the findings that we've made in this case. We see in a post-transplant liver, multiple masses throughout the liver, which are moderately high signal intensity on T2, show heterogeneous early enhancement. Some of them do partial fading, and they seem to also show capsule enhancement. Now, what's unusual for recurrent HCC in a patient who had an original diagnosis of HCC and then underwent transplant, the problem with HCC is that HCCs generally are not as bright on T2-weighted images as this one is, and generally we should see more clearly defined washout and late capsular enhancement than we saw in this patient. So I suggested the diagnosis, which was subsequently affirmed when we spoke to the clinician, of mixed hepatocellular carcinoma, cholangiocarcinoma, which is an exceedingly rare diagnosis, but this is the kind of information that you can acquire in MRI of the liver. Thank you.